Welcome to the Food Junkies Podcast. Here, we aim to bring you the experience, strength, and hope of professionals working on the front lines in the field of food addiction. Our mission is to educate you, the listener, and increase overall awareness about food addiction as a recognized disorder. Here, we discuss all things recovery, exploring the many pathways people take towards abstinence in order to achieve a health-forward lifestyle. We hope to inspire you to thrive rather than just survive. So stay positive, make a change for yourself, and share your journey with others. And hopefully the message will spread.
Welcome to the Food Junkies Podcast. In this powerful episode, we're thrilled to welcome back Dr. Kim Dennis, a leading voice in eating disorder treatment, food addiction, and integrated care. Dr. Dennis is the CEO and medical director of SunCloud Health, a treatment center specializing in eating disorders, substance use disorders, and co-occurring mental health challenges. A board-certified psychiatrist, Dr. Dennis brings over 2 decades of experience and a personal passion for supporting holistic, trauma-informed recovery. In this episode, Dr. Dennis dives into the growing understanding of ultra-processed food addiction, its impact on mental health, and its intersection with eating disorders. She sheds light on treatment protocols, including harm reduction, abstinence-based approaches, and trauma-informed care, while addressing the challenges clinicians face in balancing individualized treatment with evidence-based practices. So whether you're a clinician, advocate, or someone on the recovery journey, this conversation is filled with groundbreaking insights and compassionate solutions. Welcome, Dr. Dennis. Thank you so much for coming back to see us yet again, Dr. Kim Dennis. We are so excited to have you here with us. We just love your work. We love you. We love what you do at SunCloud. So thank you for taking the time to being willing to talk to us yet again.
My pleasure. I'm happy to be invited back, and I love what you guys are doing, and I'm just grateful to be here.
Yay. Well, let's just jump right in then. So we know that ultra-processed foods are kind of having their moment right now in the media. It's really been coming out in the last few months. We know that there was a huge lawsuit just filed not that long ago. Carlos Montero and the Nova Scale. We just had the International Food Addiction Consensus Conference in May 2024 in London. We're getting ready to do 2025. And so I'm wondering, could you explain the evolving understanding of ultra-processed food addiction? Because I think that's what we're going to end up calling it, and its implications for clinical psychiatry.
Yeah, well, I think, one of the big articles that came out in the British Medical Journal, with 9 million plus subjects, the meta-analysis that looked at the correlations between ultra-processed food and various medical conditions and showed significant correlations with cardiovascular disease, type 2 diabetes, but also anxiety disorders particularly, but all mental disorders. And I think that's a finding, and it's just a finding that we can no longer sort of ignore. So often in medicine in general, but particularly in psychiatry and particularly in the eating disorder field, we pay very little attention to what we are consuming, macronutrients, micronutrients, and the impact of those substances on our mental health, on our brains, on our bodies. We've sort of been colorblind when it comes to food, and in the eating disorder world, that's intentional, right? Because we're trying to help people who many times have extreme ideas about what it means to be healthy, or extreme ideas about dieting, or extreme ideas about what foods are good or bad. Like we talk a lot in the eating disorder world about there's no such thing as a good food or a bad food. And while I agree that putting food, or any other substance for that matter, on a moral plane, good and bad confers like morality, I think that's not useful for anyone ever. I do think it's useful to talk about foods in a contextualized way for individuals as being, useful to what you're trying to achieve or interfering what you're trying to achieve. Whether that's mental health goals, whether that's longevity, whatever the goal happens to be for the individual. We know that all foods are not created equally in a whole host of ways. The way that I'm most interested in as a psychiatrist and as a food addiction and eating disorder person is the psychoactive properties of different foods. And I think, over the last decade, for sure, we've had, just mounting evidence to show that what we might like to think of as intuition or our capacity to decide is impacted in our brains by certain foods. Certain foods are designed to tamper with the brakes and, increase the gas. So I think that evidence has become undeniable in the last 5 to 10 years. And I think we have plenty of human and animal data to substantiate food addiction, and the most practical way, I think, even though it's not perfect, to conceptualize that from a disease management and a prevention standpoint is to use the term ultra-processed food addiction. Again, not perfect nomenclature, but I think it best captures what the disease is and what are some of the causative pieces.
Definitely. And as you were saying that, you kind of started to answer what I think some of our next questions are centered around when you said, we don't really want to label these foods good and bad for different reasons, yet we can't ignore this evidence that's showing up that is saying, some of these foods that we're consuming are directly related to, or we can tie them to mood disorder or other mental health concerns. And so when we think about somebody like yourself, who is a medical doctor, a psychiatrist, you have a treatment facility where you treat all substance use disorders, including food. You treat eating disorders. You treat mood disorder. You treat so many things. It does then, beg the question, like, how does that concept then of something like ultra-processed food addiction, where we are labeling things in a way as unhelpful or maladaptive use, something's going on there. It is negatively impacting our mental wellness. And so how do you then merge that with this idea of all foods fit when we're trying to treat eating disorders? Because now I'm really starting to wonder if that's even true for people with just straight eating disorder diagnosis. I don't know. I mean, yeah.
Well, I think, the whole area of specific nutritional interventions for eating disorders is emerging. Walter Kay's group out in San Diego is doing a study looking at ketogenic meal plans for people with anorexia, which 5 years ago, 10 years ago would have been unheard of. These are weight restored people who still meet criteria for anorexia based on the cognitive distortions that they have. And there's been evidence and data to show that a ketogenic diet for those folks, a calorie replete, it's not a weight loss diet, but it's a specific nutritional intervention, may impact that person's brain in such a way that it shuts off the obsessions around weight, body size, body shape, calories, and yields a better outcome for people who are still, who don't respond to treatment as usual. All foods fit for all people all the time, which we know isn't true, because plenty of people have celiac disease or, peanut allergies or, I think there's a bit more knowledge and awareness of nutrition impacting medical illnesses in other areas of medicine. People with congestive heart failure, for example, oftentimes are on low sodium meal plans. But, it's one of the things this has caused us to do as a treatment center is to really look at our food environment. I remember reading an article, a commentary, and the doctor that was speaking in the commentary was really about public health interventions for a whole host of non-communicable diseases that continue to plague us as a country and as a world. And he said, 50 years ago, we had cigarette vending machines in hospitals. We don't have those anymore, but we still feed people in hospitals like 90% of what we feed them is ultra-processed foods, which we now have data makes cardiovascular disease worse, anxiety worse. And we're not even talking about people with food addiction. This is just, how it's impacting your health. So we've sort of been very shockingly naive. I think it's shockingly naive in this day and age to think that what we consume, whether it's food, liquid, internet material, if we believe that stuff is not impacting us on a biological level, which then at the brain level impacts our thoughts, our behaviors, our decisions. It seems like this should be obvious, but it's really not. And I don't think it's an all or nothing for people with eating disorders. One of the things we're writing about right now is, there's a longstanding sort of concern, understandably, among eating disorder professionals that if you talk about, even if you provide psychoeducation about ultra-processed food addiction, even if you utter the word in any way that's different than this doesn't exist, this is just a myth, this is just your disease, that harms people with eating disorders and causes more dietary restraint. And from cohorts that we've looked at in our treatment center, we actually see decreases in dietary restraint as measured by the Eating Disorder Examination Questionnaire. And that's across diagnoses, which is exciting to, people say like, well, you can't do that because it's going to make it worse, but nobody's really looked at it and written about it. And I'm excited to add that to the literature, hopefully in the next, 4 to 6 months.
Yeah, we're excited for you to release that too, because I think it'll allow people to pause and consider, is this actually true? Rather than it's just like kind of this thing that's uttered throughout the community that everyone has just accepted as truth the whole time. I'm wondering if you would be able to speak to how food allergies, sensitivities, and even food intolerances intersect with eating disorder pathology.
Yes. So this is another area that I'm really interested in because I'm a person who's recovered from an eating disorder. And when I think about and trauma, right, and food addiction, and all three of those have intersected for me. And when I think about how I deliver care, how we as a field in the eating disorder world deliver care, the addiction world has really shifted away from sort of like paternalistically administered, you must do this or you're out kinds of ultimatums in care. And I feel like we still do that in the eating disorder world, at least in higher levels of care programs like the one that I'm running, right? And so when I think about how we often, I feel really sad when I hear patients describe, well, I was told I had to eat wheat because it was my eating disorder that was saying my joints hurt and I get congestion when I eat, foods that are high in gluten. And, some of these patients have lupus or another form of autoimmune illness that, again, we have gobs and gobs of medical literature showing, and people's experience showing, gosh, my pain improves when I eat a meal plan that doesn't have gluten in it. And almost uniformly, we pathologize those folks in eating disorder treatment. Our default assumption is that's your eating disorder. You don't know what you're talking about, rather than tell me more about that, and if this is true, how can we support you in renourishing, regardless of what your diagnosis is, if it's anorexia, bulimia, binge eating disorder, atypical anorexia, we can support you in renourishing with a whole host of other foods and a big variety of other foods that don't happen to include gluten, so it makes it a little bit harder. And just because it's harder to give you the best outcome possible for both issues doesn't mean that I'm not going to walk that walk with you and support you and work with you in figuring out a way that's going to make sense for your body. So I think food intolerances and sensitivities are real. I think it's very hard, especially for new clinicians and young clinicians and organizations that have to take sort of a party line to meet patients with nuance and with discernment and help them figure out, by doing the experiments, what's going to work for you and what's not.
I just imagine myself being a patient, maybe, that's going to a provider of something. Maybe it's my registered dietitian. Maybe I'm coming to inpatient something. And I'm just like imagining like saying these things, like, I'm already scared. I know I need help. I mean, it probably took an act of God to get me to walk through doors of a residential facility, all of these things. And then I sit down and I'm saying, when I eat these things, this is my experience, or I don't eat these things because of this. And then for somebody to say, well, that's just your eating disorder. I just, like, Kim, I could cry just thinking about that right now. I mean, I'm not trying to be dramatic. Like, it's making me emotional to think that people experience that.
Yes. And it adds to the shame that people already feel too, and the trauma too, the trauma of not being seen, of not being believed. I think we need to listen a lot more to our patients. I think we'll learn a lot more about effective treatments for eating disorders the more we listen to our patients. And so many people with eating disorders never make it to treatment because they read about treatment and they say, no, thank you. I'm not even going to put myself in that sort of environment. Right. So I think there are lots of people that we're missing in the community who really could use help and who never avail themselves of it because of the way that it's historically been administered.
Yeah. Well, and then to have that same potential invalidation if somebody were to come in and say, like, I think this is true. Like, I think I'm actually addicted to these foods. I don't think that I eat them in any sort of way that's considered, what could be considered normal. And I think it's more than eating disorder behavior or symptoms. And then to again have that being said, well, that's not real. That's false. And in fact, we're not going to talk about that at all because you might hurt somebody else. You might hurt somebody else if we talk about that thing. And so I'm curious, in the context of eating disorder treatment, how can clinicians balance the goals of avoiding diet culture, which obviously I know we're all on the same page there. Nobody really wants our patients, our clients to be embroiled in that, and address the harmful foods that do, whether it be because there's an intolerance, an allergy, maybe there's a substance use disorder, or even some of those other things you were talking about where we're not even talking about food addiction, but we're talking comorbidities where it makes things worse. Cardiovascular disease, diabetes, non-alcoholic fatty liver disease, cancer, you name it. So what can we do? How do we balance those goals?
Yeah. So it has to be individualized, and it has to be holistic. I think that's another piece that in medicine, we have a very fragmented healthcare system in our country, and our mental health care system is just as fragmented, right? So if I'm the psychiatrist and I say, well, you have treatment-resistant depression, I'm going to add, or you have bipolar disorder, I'm going to add Seroquel, quetiapine, which is a medication that's associated with increases in appetite and weight gain. I'm just going to add that to your regimen because it's the best one for your bipolar depression. If I do that sort of in a psychiatric vacuum, without respect for, does this person have food addiction? Does this person have binge eating disorder? Does this person have anorexia? Does this person have type 2 diabetes and heart disease? I can't possibly make the best medication recommendations unless I'm taking all of that into consideration. What's your culture? What's your ancestry? What's your family history? How about that? Or even what foods do you have access to, right? So many people in our country have access only to ultra processed foods. People who are, low SES categories, who are economically deprived, don't have access to a basic right, and couldn't possibly eat intuitively because there are certain privileges and prerequisites that you need to have to be able to eat intuitively, right? Safety is one of them. Access to a whole variety of foods consistently is another one of them. And that's just not something that everybody has, So we have this picture where, you have the eating disorder field over here that's small but mighty, saying all foods fit, all foods there's no such thing as a bad food, and eat intuitively. You have a whole swath of the population who doesn't have access to eating disorder care, who has inconsistent access to any food. And when they do have access to food, it's ultra processed foods overwhelmingly. And this medical literature that's showing the sort of like death sentence that puts people on from a cardiovascular standpoint, from a diabetes standpoint, and now also a mental health standpoint. And I think in the food addiction literature, it's pretty well established, again, because of the psychoactive properties of foods designed in laboratories by, billion-dollar corporations to increase consumption, that, people who are eating, when people are binge eating, they're not binge eating on broccoli most of the time. Yes, that does exist, but the majority of people, when they overeat or binge eat, are eating foods that are highly addictive.
I'm wondering if you could speak to the treatment protocol that you often use. And, Molly and I are both harm reduction clinicians. And even in our field, with ultra processed food use disorder, food addiction, we get pushback sometimes, because how can you be harm reduction and also support people who are abstinence based? So you have 3 treatment protocols: treatment as usual, harm reduction, and abstinent based. I'm wondering if you can speak to each of those and how they fit the unique needs of the diverse population with ultra processed food addiction.
Yeah. So this was a treatment protocol that we developed for patients who are at our eating disorder addiction comorbidity unit. So all of these patients have an eating disorder. The majority of patients that I treat have OSFED, other specified food and eating disorder, atypical anorexia, binge eating disorder, and a smaller group with bulimia and the, lowest percentage anorexia. Many of them also have comorbid alcohol or drug use disorders. But a high percentage of them also have ultra-processed food addiction. And so an important part of the treatment is educating people about what it is and how we measure it, which most eating disorder places would never, ever, ever even consider doing. And I've gotten a lot of pushback from many eating disorder colleagues, other treatment centers, saying it's like shocking that you would even administer a modified Yale food addiction scale to a person with an eating disorder. So we do that. We measure eating disorder pathology with the eating disorder examination questionnaire, a whole host of trauma questionnaires, because that's usually in the mix too, other mental health and quality of life questionnaires. So based on those scores and clinical interviews, a person may have, binge eating disorder or OSFED and scores, a 5 or a 6 on the Yale food addiction scale, right? Which is of clinical significance in the moderate to severe range. And first of all, we let the person know what their scores are and what they mean. Just like if I did a blood test on somebody and someone was like, what were my results? We would actually tell them what they were and what it could mean. So we follow that same process with the tests that we administer that are psychometric scales. And, once we talk to the person a little bit more, we describe, the various treatment options that they have. And I think it's important to leave people with a sense that, and a reality that they have a choice, in different treatment options. And treatment as usual would be eating disorder treatment as usual, which is food agnostic, like all foods are. We're going to feed you with all different foods. We're going to do challenges that include all different foods. Most of the challenge foods will be highly processed, desserty type foods. And that works really well for people who have a lot in the way of dietary restraint as driving their eating disorder and even potentially driving their food addiction. Or people who are underweight, who have high, food addiction scores because they're starving, regardless if they're in a larger body or smaller body. That approach does not work so well for people who have food addiction. It also does not work so well for people who've tried it like 5 times in other treatment centers and it hasn't worked for them, or it hasn't sustainably worked for them. So all of these approaches include, none of these approaches are diet approaches. I think it's important to understand that. Like, these aren't about, let's help you lose weight. Some people lose weight when they stop binge eating. Some people maintain their weight. Some people even gain some weight. So the goal is not, for any of these approaches, is not diet, calorie restriction, lose weight. The other piece that's included in all of them is working on body acceptance, working on trauma recovery, which I think is intimately connected with body acceptance and body appreciation, and combating, the thin ideal that we see in social media and pretty pervasively. So treatment as usual includes all of that. Harm reduction, which most of our patients opt for, can look different ways for different people. And I think this is part of why it's not used so much at the treatment center level, because people in treatment centers want, like, well, what's the policy or the protocol, So if it's harm reduction, does that mean only 50% of their dietary intake instead of 70% will be ultra-processed foods? Or does it mean like this one particular type of ultra-processed foods they're going to leave alone? Or does it mean they'll have this type of ultra-processed foods only in the context of like being out with friends, with support on one end and the other? So it can look many different ways, depending on the person. And that requires individualization. That requires us like thinking a lot as clinicians. And sometimes people just don't want to do that, I guess, but it's really, I would say the overwhelming majority of people who score positive on the MyFAS in our treatment center opt for a harm reduction approach. And that's very individualized. And it's, it's like an individualized nutritional prescription made with a nutrition therapist, a dietitian. Again, not about weight loss, not about calorie restriction. It's about eating at regular intervals, throughout the day to maintain as steady as possible blood sugar. And then there's an abstinence-based.
Before we go to that, Kim, because I totally want to talk about that. Absolutely, we have to. I'm curious about the harm reduction aspect of it, the treatment of it, and and knowing that a lot of clinicians or agencies or facilities don't really want to go to that place. And I think you're right. Some of it is because it would require that nuance and it's extra energy going into each individual patient, which I think on the surface, absolutely, I'm quick to go there too. Like, well, come on, guys. Like, it's not that much more, if we really want to be helpers, which we are in helping professions, why would we not do that? But like, I think the therapist in me wonders too, is it because if when we offer harm reduction as an option and they're more like, it's more individualized, it's more like the patient, the client is basically running the show to an extent. Like there's yes. Input, right? Okay. So what I wonder is, does it open a can of worms? Is it because the person, the professional in quotations, is it because it's big feelings for, right? There's so many big feelings. And if I open that can of worms, if I let that person have a say in this, now other patients in the same facility are, why is that person eating the chocolate muffin and that person isn't? Now there are questions, and now there's even more work that I have to do. And there's big feelings all around. There's big feelings on the part of the person that I'm, highly encouraging to eat this muffin. There's big feelings on the part of the person who's like, I'm not eating that. And not only that, but like I myself, the professional, am having big feelings. And now there's a lot of feelings to have to manage. And I wonder if the deeper level is more of like, sometimes the helpers are not regulated either. And so it's like, it's easier to shut people down and go back to, like we were saying, like this very regimented, if everybody just does it the way that I say that it's going to get done, then there are no ifs, ands, or buts. This is how it goes. And then it's so much easier to decide who passes, who fails. And I just have to do the protocol. I just always have to do the protocol the same. Therefore, then you don't have to experience all of the, like all of the feelings. I don't know. Maybe I'm totally.
We're a highly traumatized field, treating
Yes.
highly traumatized patients. And I think
Yes.
often we collude with avoidance of affect, avoidance of feelings, avoidance of, nebulousness, because avoidance of not knowing, because, I think oftentimes treatment professionals, like the thing they least like saying is, I don't really know,
Yes. But to not even like tolerate the big feelings, of not knowing, of being in the unknowing space, not even being willing to tolerate that the person in front of me is going to have some kind of response, as they should be able to whatever it is that's happening. Like we strip that away when we say, no, it's going to be a very specific way. If you're coming to my treatment center, this is the protocol, period.
Yeah.
I don't know. Sorry to get us off track.
There's a containment factor in
Yes.
there that finds everybody's anxiety and makes people feel like safe.
Yes. So harm reduction. So treatment as usual is one tool. Harm reduction is another. And then you guys do abstinence based as well. Sorry, go ahead.
Yeah. Very few people opt for an abstinence-based approach. And I think when people have opted for it, it's been people who have tried other approaches, who are scoring in the severe or extreme range on the MyFAS. And, I think there's a lot of pushback against abstinence-based approaches, because people are like, well, how could you possibly do that with our food supply chain right now? Or how could you do that because nobody does that? Kind of like when everybody used to smoke, how could you possibly not smoke if, everybody around you is smoking? And there are plenty of foods that don't include added sugars, added preservatives, added fats, that can be eaten, in a whole variety of ways, from detailed sort of preparations and food prepping to quick foods that are of a whole variety, like whole grains, whole foods. So I think you can't possibly do that is just we don't want to put effort into learning how to eat a different way. Or it's not possible. Like, what are you going to do when everybody's having birthday cake? And these are therapeutic issues that we talk to people about. Just like at weddings, when somebody is a sober alcoholic, they're not, they will cheer, they'll do their, I don't even remember what you call it. Cheers.
The champagne flute with sparkling water.
Yes. So we'll do that with sparkling water, and there's a social and cultural piece of food that I don't think is contingent on the food substance itself, so cultural and social events can still be at their heart about connecting with other human beings that you have an affinity for, that you have a connection with, right? And the food becomes, a part of it, but it becomes a part of it in the right order. It's not like, ooh, let's go there and get this food, or like, I'm going to go to that party because they're going to have good alcohol. It becomes about going and connecting with other human beings and nourishing yourself in ways that actually nourish you and don't shoot you in the foot.
Yeah, so it's no longer like the main event or like the source of our entertainment. It goes back to what it should have been about, is connecting with the people that are so important to us. I'm curious, and you may not have an answer to this, for those individuals that, you meet them where they're at and they're like saying harm reduction is the way I want to go. Do you find that they then kind of navigate and figure out a way to become more abstinence-based over time? I don't know if you have any research or data on that. I just have personally found clinically that when I work with someone and I start with harm reduction, that they then learn themselves and figure out which foods actually work for them and which ones don't, and are able to then feel empowered in making that choice to say, actually, I've tried this a few times and it's not a good fit for me. And so they end up leaning more towards abstinence.
Yeah. And I think that work happens, we see that work happening more in the longer term outpatient arm of treatment, because as you might imagine in residential, where the kitchen is locked and the cabinets are, like I don't have access to food 24/7. I have access to food at certain times of the day. A harm reduction approach, while I'm surrounded by 24/7 support and peer support and staff support, might work quite well. And then I go home to the food supply out there and the advertising out there and my home stressors and having to cook my own meals all throughout the day, every day, and cook for a family. And that may no longer be such a viable option, and I think, the word abstinence is like a really bad word in eating disorder circles. And, there's been a long-standing, since Fairburn, like back in the 90s or early 2000s, coined the transdiagnostic sort of trait of dietary restraint across eating disorders as being like causative and pathological. There's a whole bunch of studies that really like push back on that and show actually the opposite, and that it isn't. So there's this concept of adaptive dietary restraint that I think is the future, both for the eating disorder world and for the food addiction world too. And I like the term adaptive dietary restraint. I think it's a more accurate and more empowering and more realistic construct than intuitive eating, precisely because the way that foods are made now, that, people think they are eating intuitively, but we know the foods that people eat affect how much of the foods that people eat. We know that from Hall's study at NIH that looked at calorically equal diets, meals, and, composed either of whole foods or ultra-processed foods. And the people who were eating intuitively the ultra-processed foods ate a lot more of those foods. Certain foods you eat.
Yeah, they had a maladaptive response to those foods, right?
Well, they had a natural response to foods that caused them to behave in a certain way, and I just don't love the idea of the CEO of Kellogg's Foods or Quaker Foods making my choices for me or influencing my choices. I will take my intuition without that sprinkled on top of it 1,000 times out of 1,000. And I can do that from an anti-diet perspective. I can do that from a body acceptance perspective. And I can do that from a place of inclusion.
Definitely. So thinking about, I love your phrase, adaptive dietary restraint, by the way. I think the Society of Metabolic Health Practitioners uses the term therapeutic carbohydrate restriction, which probably is problematic in the eating disorder world because carbohydrate is such a broad term, but they're certainly not talking about broccoli, cauliflower, Brussels sprouts, carrots. That's not what they're talking about. That's not what they're talking about. But I do like your phrase. I agree. And so thinking about from that inclusive place, something you touched on earlier was trauma and PTSD, and those are often significant comorbidities in clients with ultra-processed food addiction, eating disorders, addiction in general. And so how does trauma-informed care then really influence outcomes of treatment in these cases?
Yeah, I think it makes it or breaks it, honestly. Around 70% of our patients meet diagnostic criteria for complex PTSD and dissociative subtype of PTSD. And I think that dissociative, when we think about, mindless eating and binge eating, people aren't eating and really mindfully eating and, present with themselves or with anything around them. They're eating to check out. So it's a form of dissociative behavior that sort of like stems right from dissociative experiences that are actually quite adaptive if you're a small child in an overwhelming sort of situation. So I think any treatment that is not trauma informed, that is treating food addiction or eating disorders or substance addiction, is going to suboptimally serve the people that they're trying to help.
I think that this is such an important conversation because for years I've felt the same coming from a mental health substance use disorder background treatment wise. I've always treated those things at the same time if necessary. And there are people I don't know about in the eating disorder world, but I know we have colleagues in the food addiction world who are adamant that if you're just sober, abstinent for 2 years, that all of that stuff will be fine. Like it's not really, it's the substance. It's not the trauma. It's not
true.
No, I know it's so not true. I know it's so not true. And I think that's been one of the biggest reasons why I've had to separate myself from, some individuals in the field of food addiction, because it's so, in my opinion, as a mental health professional, harmful. It's just so harmful and shameful and all of those things. And so it's really good to hear that. No, yeah, listen, when we treat the trauma, even if we're not directly treating trauma, but we're trauma informed, meaning we are going to do our dang best to not cause more harm, to not shame, to not whatever, that the outcomes actually, they make these cases. Like this is like the thing that makes it possible for somebody to get better.
Yeah. And we know from the research on substance use disorder that integrated treatments for trauma and substance use disorder have much better outcomes. Like that's quite clear from the literature. And there haven't been too many studies of treatments for ultra-processed food addiction as this thing that doesn't even exist and that's, made up by the devil. But I would expect that we're going to find the same thing because it's the same disease in the brain. If we believe that addiction is a primary brain disease with, psychological, social, emotional, and spiritual manifestations, physical manifestations, the food is a piece of it, but just putting down the food isn't gonna, impact all the other stuff that's around it. And many people won't be able to stay sober with food for a year or 2 years or even 6 months if the trauma is not addressed from the outset. Like we used to say similar things in the substance abuse world, right? Like stay sober for 2 years and then maybe we'll prescribe you a medication, or stay sober for 2 years and then you'll be stable enough to work on your trauma. Similar with eating disorders, like once you're fully weight restored, we'll start to work on your trauma. Or once you've stopped binging and purging for X amount of time, arbitrary X amount of time,
And I think like I can see, before we had brain imaging stuff, before we had the amount of research literature we do now, I can see how people would be at that place because it was just like experience, right? Sitting in 12-step rooms or the therapist room, whatever it might be. But we know better now. And I feel like it's time to do better. And if you're not doing better, what is going on? What is the hang up?
I also think some of those treatment programs were based on 12-step programs, which called these outside issues. Right. And so that is also what happened. And so they weren't discussed and nobody was comfortable discussing them. So I think that also probably played a big role in it too. And now it is so much about like science and informed care and it's just elevated to a new treatment level, which is so wonderful that, is not just based on peer support anymore.
Yeah. And there are evidence-based treatments for co-occurring addiction and trauma, like prolonged exposure, cognitive processing therapy, EMDR. There are a lot of somatic approaches that have varying amounts of evidence base. So there are good treatments for it, At the very least, if we don't, if we're not well-versed in any of those treatments, we really need to be referring our patients to people who are while we're treating them.
Yeah, specifically when it's outside of our scope of practice. And we can identify that it's something that needs some support. Absolutely. I'm wondering, Kim, if you can speak to, given the controversy surrounding ultra-processed food addiction and you being such, somebody who speaks loud and proud about it within the eating disorder community, how do you engage with skeptics among the clinical community that you're in?
Yeah, so I direct people to the evidence base a lot. I've done a lot of work trying to use the right language in the right spaces, and really to understand where, from historically in the eating disorder field back in the 80s and 90s, where some of these biases come from. And I always start from a place of we all want the best for patients. So oftentimes, I feel like what works best is to start with a patient case, because it's hard to argue with a person's lived experience. I've also, sort of come out of hiding myself in the eating disorder world. And just, when I was on a panel at the International Conference on Eating Disorders on GLP meds. And when I introduced myself as a person with lived experience with recovery from bulimia, alcohol use disorder, trauma, and food addiction. And, in the eating disorder world, like many, 10 years ago, people probably would have been like throwing things at me. And I think there's been a little bit of a shift. I mean, people were polite, they clapped, they seemed like genuine. So, like some part of it is just advocacy at that level. Like I'm a physician, and I'm also a person who has lived experience with a lot of recovery from food addiction and an eating disorder, both, and both were intertwined. And I couldn't necessarily, like, I think I often say I would have died in like standard eating disorder care. Like that would have killed me, I believe. So I've always been a big fan of working like with patients in individualized ways that are tailored to them, recognizing my own bias and where it comes from, and knowing that what worked for me isn't going to work for everybody else out there, and just because something different works for somebody else doesn't mean I'm wrong or they're wrong. Or so, both from a research perspective, I direct people to the literature, and from a lived experience perspective, I try to engage people, and I think it's such an exciting time right now because, 20 years in the eating disorder field, and all of the arguments against it are being sort of like peeled away one at a time. So I'm excited. And I think it's actually going to help a lot more people. The recovery rates for binge eating disorder, the long-term recovery rates are pretty abysmal, and they're 30 to 40% of patients we can't help at all with our best tools right now. That's a lot of people, so I think we're going to be able to touch a lot more people and help a lot more people as we broaden our philosophical models, our theoretical models, and our treatment models.
Well, that is a beautiful way to wrap this, because that was going to be my next question is, what do you think the future of research in ultra-processed food addiction, eating disorder worlds, how do we integrate those into mainstream eating disorder treatment to have the best outcomes to reach these 30 to 40% of people with binge eating disorder that, treatment is failing them. They're not failing treatment. Treatment is failing them. So what do you see as like what's coming down the pipeline in the research?
Yeah. So I think as ultra-processed food addiction is gaining more momentum, people will be more willing to study it. And people on the ground, people like in the trenches have been working with people on it for many, many years. And once it becomes more legitimized, I think there will be more grant money devoted towards examining it. I think private treatment centers like the one that I run, my hope is that there are more and more people saying, yeah, we'll be involved in that research too, and we'll study it too, so that we do develop some amount of evidence base for how to, now we know this is a real thing. Patients have been telling us for decades it's a real thing. So now we finally believe them. And then the next phase of it is, how do we individualize care? How do we match care to what the individual has and what the individual prefers to achieve the best outcomes?
Yeah. I'd also be interested in research of the professionals themselves. Like, can we do some sort of, baseline? Where do these individuals meet criteria, and to what extent? And are they seeking their own help around those things, their own help and support and treatment plans around those things. And does that also then correlate with the outcomes of these programs or treatment protocols or whatever they might be? I don't know. Maybe that's too big of a hope. I don't know, but I imagine it would.
No, there was a study actually on that, Molly, like sometime within the last year that looked at eating disorder measures, that looked at cognitive rigidity, and showed that eating disorder professionals have like the highest cognitive rigidity. It's like actually a study
me not picking my jaw up off the floor. No, not at all.
that showed that. And I was like, well, that makes sense.
Yeah.
The way I'm not surprised. Unfortunately, I mean, I'm not trying to make light, but it kind of makes sense. Yeah.
Well, and I think too, a lot of people in the eating disorder field will look at food addiction treatment in a way like the colleagues that you describe who are like, it has to be abstinence-based. You are doing harm if you introduce any amount of ultra-processed foods to people with food addiction. Those are the voices that the eating disorder world hears, and it's really like the only voice they hear. And that's such a tiny percentage of the treatment that most people are seeking and doing.
Right. It's called #confirmation bias. Your research is showing us, or maybe not necessarily your research, but like your numbers in your clinic are showing us people are actually attaching themselves to harm reduction more so than abstinence-based tools. So yeah, it's so interesting.
And even, the eating disorder field could stand to grow from more in the way of harm reduction for people with, severe and enduring eating disorders who, aren't gonna do X, Y, or Z, okay, short of that, like what areas of your life can we help you improve on and how can we help you stay out of the hospital and stay alive,
Yes, that's it.
And that's the ultimate goal of harm reduction, right?
Yes. Staying alive long enough to get the help that you deserve, that you want, that you need, all of the things. Oh, thank you so, so, so much, Dr. Dennis, for being here with us today. We love you so much. We love everything you're doing at Sun Cloud Health and everything you're doing in the fields of eating disorder and food addiction. So I'm sure we'll have you back again because we just can't get enough of you.
Awesome. It's great to be with you guys. And thank you for all that you're doing for food addiction and for people who have it.
Thanks for joining us this week on Food Junkies Recovery from Food Addiction. Make sure to join our Facebook group, Sugar Free for Life Support Group. I'm Sweet Enough. Molly and Clarissa are food addiction professionals who offer one-to-one counseling and group coaching through Sweet Sobriety. Please subscribe to our show so you never miss an episode. While you're at it, if you found value in today's episode, we'd appreciate you leaving us a review on your favorite platform. Your feedback helps grow our show and allows us to reach others who need to hear this message of recovery. Don't forget to pick up a copy of Dr. Tarman's book, Food Junkies. And as Vera always says, the power is ours.